thing that everybody's got to fix. And we can talk about how you fix that. So why
Okay.
do we wake up? This is a good question, and this is something I do. Why do we wake up at night?
I love starting with that question because I did a whole TEDx talk on that a few years back. I think it's garnered about 750,000 views. And it talks about, it's actually called uh, Why Do I Wake Up? Let's see, I think it's Why Do I Wake Up at Night? Something very close to that. Most people, when you do research on that question and you ask people who wake up at night, they don't know. They'll actually say, well, I don't know why I wake up. And in the research project we published more than a decade ago, we said, well, let us give you some answers. Let's say, do you think it could be stress? Do you think it could be going to the bathroom? Do you think it could be nightmares? Could it be insomnia? In other words, just gave them 20 different things to pick from. Well, from that list, they pick lots of things. But at the end of the interview, we said, okay, well, you pick all these things as possibles. Tell me now, what do you think is the reason you wake up? And the answer of the majority of the patients in the study said, I don't know. And they go, how could I know? I'm asleep before I wake up. And so this raises the interesting paradigm, right? Because if you are asleep and then you wake up, who are you going to rely on to figure it out? Because if you would read books, newspapers, listen to doctors, listen to health coaches, the first response to that is, well, everybody wakes up at night. And the older you get, the more you wake up at night. Another component of that would be, because it's extremely common, well, everybody wakes up to use the bathroom in the middle of the night. And as you get older, everybody wakes up more times in the middle of the night to use the bathroom. It turns out all that information is incorrect. It's incomplete. It's invalid. And there's so much other research to explain why people wake up. And that is so crucial in terms of understanding one key point, and that is lots of people wake up, roll over, and go back to sleep. So those people, as you can imagine, are not that interested in the question. Like, who cares? I roll over and go back to sleep. There's an enormous number of people who have trouble going back to sleep. And here's the key aspect. What is their awakening like? Their awakening is not like the person who rolls over and go back to sleep, who is experiencing the feeling of sleepiness. So they can roll over and go back to sleep. The person who wakes up and is wide awake is going, what happened? Like, how is this even possible that I was sound asleep and then now I'm wide awake? And, some people say, well, I woke up because I had to pee. So they go to the bathroom, they come back to bed. Some of them go back to sleep, but then again, some of them don't. And this is actually the single most common sleep complaint in the world, or at least Western civilization, where people wake up at night and can't get back to sleep. That's called middle of the night insomnia. And because it's so common, you would have thought that lots of great research would have been done by now to say, well, what's waking them up, and how can we treat it? And very little research has been done on that. Most people think it's psychological. You must have had a bad dream. You must be worrying about something. You must be stressed out. And of course, that is a sort of a logical answer for one reason. If you wake up and you're kind of wide awake, you will start worrying about something or thinking about something. And so then you might go, well, wait, if I'm thinking about what happened at work yesterday or what's going to happen at work tomorrow, maybe that's the thing that woke me up. Maybe I'm just carrying on the conversation that was in my head. So I used to think that. Everybody used to think that, and people still do think it because research does not disseminate rapidly. We did this study in 2012, and we took 20 individuals who had moderately severe insomnia, were waking up at night 25 times a night in a sleep laboratory. They had no idea why they were waking up. We specifically chose people who should not have a physical reason for waking up. For example, they weren't sleepy during the day. They didn't have snoring or breathing problems. They were not overweight. And in 90% of their awakenings, we proved there was a sleep breathing event just prior to the awakening. And now, if you think about it, makes crystal clear sense in terms of what we call in medicine and research parsimony. One thing explains many. Of course, you're wide awake after a breathing event, because what is a breathing event? It's a primal attack on your life. It's a mini suffocation event. Therefore, your heart's going to pump harder, your blood pressure is going to go up, your heart rate's going to go up, your mind is going to race, but you never knew any of this because you were asleep before it happened. And then when it happens, you wake up and you go, oh, why am I waking up? And we showed in that study and then in a later study that literally an enormous percentage of insomniacs have this sleep breathing problem.
Do sleeping pills help them sleep through the breathing event?
Great question. So sleeping pills, by and large, don't work or don't work regularly for long term for most people. Most people who try sleeping pills don't like them. Most people who use them say, well, it didn't really work that well. There is a cohort, a group of people who use them regularly because that's all they hear from their doctors. Somebody says the word insomnia or I can't sleep, they pull out the prescription pad, they just get it. Or people just go to the drugstore, try over-the-counter remedies. But your question gets to the heart of the matter. What is the reason a sleeping pill could work? And the answer is exactly part of what you're getting at. I have a colleague at Stanford who told me that for very subtle breathing event patients, in the field, we call this UARS, it stands for upper airway resistance syndrome. And I should say that I delve into all of this in my new book, Life-Saving Sleep, that when a person takes the drug Ambien, as an example, it changes the arousal threshold. So that means the person could still have the breathing event because the Ambien is suppressing that activity. Some of those people who have that experience will say that Ambien is helping them sleep better. So that's glorious for those individuals. Unfortunately, it's not most people. Most people's sleep breathing problems in insomnia are more severe or moderately severe, such that the sleeping pill often doesn't work. And this is why it's so incredibly common to hear about insomnia patients, like friends, colleagues, who go, well, I was on that drug and it was working for a while, but then it stopped working, and so they put me on another drug. And then they repeat that cycle for years of trying different drugs that come out, and some of them are, yes, increasingly better pharmacologically, but none of them treat this underlying problem of sleep disordered breathing.
So what is the correct way to treat insomnia, and why do so many doctors or therapists not know this information?
Well, the field of sleep medicine is relatively new, and it's also a kind of orphan field because there's so many aspects of sleep that just don't resonate in healthcare. Society in general discounts sleep. People make jokes about, people who are slothful or lazy. They just want to nap. What's wrong with these people? So the field of sleep disorders medicine has not done a good job of broadcasting the fact of how tightly linked physical and mental health is to our sleep. So that's problem number one. Like if you don't have the society and the whole and the healthcare professions involved, you're never going to get the message across. I can write a book, and the book can be packed with lots and lots of information. But if people don't read it, people don't hear about it, the way things change in life, there's a very slow trajectory. And that's what's going on with sleep. Regarding what people could learn in my book and my website, and there's other researchers out doing some similar stuff, is to recognize that everybody with insomnia, literally anybody with chronic insomnia, particularly anybody with chronic insomnia who has failed the medication, that person has an 80-90% chance of having a sleep breathing problem. That means the doctors talking to them should say, well, your problem is psychological and it's physiological, and we're going to treat both. So that's the heart of the matter when it comes to this issue. And you don't see that, because you see the psychologist and the behavioral sleep specialist saying, well, we have something called cognitive behavioral therapy for insomnia. We have sleep hygiene, and we're going to talk to you over here. And then over here, you've got a few sleep doctors, or maybe more than a few now, who recognize that, well, wait, I've got to treat the sleep apnea in my insomnia patient to make their insomnia better. But are these two groups talking to each other? No. And that's why, the program that I'm doing right now in Savannah, Georgia, I'm installing a sleep medicine curriculum into the psychiatry residency training program. And so in that program, the psychiatry residents, before they pull out the prescription pad, are now understanding that many of their patients have to get a sleep study before they even address the sleep problems. So it's a complex, set of treatment modalities that have to be organized at this point in time. God willing, things become more integrated because more mental health professionals, more health coaches need to pick up on this and realize how much this physical component has to be treated along with the psychological.
Why do you say that post-traumatic stress disorder can be renamed post-traumatic sleep disorders?
Well, that harkens back to how I got into the field. I started in 1988 working with a group of psychiatrists. I'm an internist and a board-certified sleep doctor, but my career from 1988 onward has always been working with mental health professionals and mental health patients who have sleep problems. With the professionals, I'm training them how to treat the sleep problems in their patients. So because that happened, I became so attuned to the idea of sleep is a big deal. It really makes a difference when you treat somebody's nightmares or their insomnia or their sleep apnea. And so over the years during the 1990s, what we discovered was, because we did all this work on chronic nightmare patients, it got published in JAMA. It was such a big study showing that if you treat nightmares, you actually make PTSD get better without any drugs. But these same patients, we discovered, had so much more complexity to what was going on. We were shocked. We thought they had nightmares, but it turns out they have nightmares and insomnia. But then it turns out they have nightmares, insomnia, and sleep breathing disorders. Then it turned out they have nightmares, insomnia, sleep breathing disorders, and sleep movement disorders called parasomnias or restless legs and leg movements. And I haven't finished. I mean, it just goes on. So PTSD patients are a perfect living, breathing example of this complexity. And again, going back to this concept of chronicity and, throwing drugs at things, there are so many stories out there about people who had PTSD, horrible PTSD, engaged in self-harm activities, suicidal behavior and ideation, and sadly completed suicide. And if you look at these stories, you can find them all over the media to this day. All they talk about is, and the doctor gave him a higher dose of Seroquel, and the doctor gave him more sleeping pills. Nowhere in this story, nowhere about somebody who had a completed suicide the media has reported on, have they mentioned that that patient was evaluated by whom? A sleep doctor, and went to a sleep center and got sleep testing. Nowhere. I've never seen a media story like this, and these people continue to commit suicide. And so in the PTSD literature, more and more doctors and more researchers are demonstrating that sleep apnea is very common. Many don't agree with me when I say the rate has got to be close to 80 to 90%. But so what? You've got research PTSD doctors saying, well, I think it's 60%. Oh, 60%. That's every other person or more has this problem with PTSD. So post-traumatic sleep disorders actually defines to some extent what goes on in the intractable cases, because the people who are not doing well with their PTSD almost always have intractable sleep problems that nobody is really dealing with in a full, comprehensive way. And it's very, very disturbing because there is so much mileage to be gained by saying, no, we're going to treat their nightmares. We're going to treat their insomnia. We're going to treat their sleep apnea. And everything I just said is without drugs and is not being done.
That's kind of sad.
Well, that's why I wrote
Very
this book.
sad.
And that's why it is a lifesaver, because people who read this or get their friends, family members, or other mental health professional workers to understand this complexity, they'll realize, yes, it's sad for the past,
But it
but
doesn't have to be.
yeah, but aspirationally thinking, I mean, there is so much potential to help people by getting them involved in very good sleep medicine treatments.
Why is sleep quality more important than quantity? And I mean, how does that balance out?
I love that question because it again targets what the media's problem is and trying to explain stuff to people, because they take research studies and they try to dumb it down, and because the media is not very curious anymore, doesn't you don't really see, you have to search for investigative journalists
Mhm.
who really dig into things. You have to watch podcasts if you're going to get actual information that's usable, accurate, clear, complete. And so, because that's not what's happening, um, we have to figure out what it is that's actually going to get people connected. Ask your question again, because I think I want to make sure I'm addressing it. You're talking about quality and quantity, and I'm trying to get across that so much in the media keeps driving home this idea that it's all about the 8 hours.
Right.
And that
So,
number is already false, because we know the answer is really 6 to 9 hours or 7 to 9 hours, and it's so individually dependent. But that's not even the big issue. The biggest issue, is you asked in your question, is sleep quality, because when you have a sleep breathing problem as the best example, not the only example, but the best example, you're destroying the individual sleep quality. That's what it means to wake up, during the night. You're destroying somebody's quality. So that drives the sleep complaints of most people, even if they want to talk about the number of hours.
what do you think about the sleep trackers? Do you recommend those to be able to tell the quantity and the quality? And I know that they rate your sleep for you.
Right. I recommend them highly, but probably for different reasons than the people who would get them would understand. Most people will get it because they're going to say, well, number one, I want to see how many hours I am sleeping. I want to see that. And then number two, they're willing to look at what the algorithm says about their sleep. It's going to say something like, oh, well, you're getting 20% of delta, so you're good. Or you're getting 20% of REM, so you're good. These trackers have information that's not perfectly accurate. In some cases, it's wrong, but in some cases, it's somewhat accurate.
Mhm.
So let me tell you a funny story because this gives the example of how I would want people to use these trackers. I met an individual who had one of these watches, and he said to me, so it's showing me that I have this amount of light sleep and this amount of deep sleep and this amount of REM. And it says that my numbers are abnormal, that I'm having too much light sleep. And after giving him a little discussion about, well, what causes light sleep, and of course, asking specific questions about his health, it was apparent to me that he could have had a sleep breathing issue. So I said to him, why don't you go out and purchase some nasal strips? Because there's many different brands out there, and we've done research on this idea. I said, put on a nasal strip every night and watch what happens with your tracker. And so he came back very soon thereafter and said, this is really weird. Like on that nasal strip, not only am I breathing better, but I'm sleeping better. And you know what? My tracker showed that. I have less light sleep now when I use the nasal strip. And so this was a discussion that eventually led this individual to realize that he had a sleep breathing disorder. And now he currently uses a nasal strip and what? A PAP machine. So he went through all this process. And this brings me to a very, I think, interesting idea in terms of treatment management. This area is incredibly complex, as I said at the outset, but there are some simple things you can do for individuals to jumpstart the process, like I did with this individual who used the nasal strip. And see, when you do that, now you give control back to the individual instead of them relying on the sleep doctors so much, which they will have to rely on later on. But in the early phase, this gentleman and many people I've worked with in the past, they'll go on and use nasal strips for a couple of years and go, no, this is my treatment. I am really getting benefit. Now we add to that things like, what about nasal hygiene? What about, do you have allergies? Do you have congestion? Do you have stuffiness? Well, you can treat all of that. What about the position you sleep in? You can change to different positions that will actually reduce the severity of your sleep breathing. And so going down that pathway, what's so valuable about it is the tracker is trying to give the individual something about the quality of their sleep. It's saying light sleep or deep sleep. That's a fair assessment of quality. Well, if they start doing these things to improve their nasal breathing, they will discover that their wearable is going to show they're moving in the right direction. Now, for some people, that's all they want. But so what? That's great. They're already moving in the right direction. They're already sleeping better just by doing these simple steps. Like we learned 20, 25 years ago, if you take some of these individuals and say, I want you to go out and buy nasal saline rinses. That's it. Or make it up yourself. Make up salt water and get, a squeeze bottle. Irrigate your nose 3, 5, 7 times a day. Get all of the junk out of your nose. And most people who have these problems don't realize how much junk they have in their nose, because there's a word in the scientific literature. It's called inspissated, and it means you get congested up here, but it all dries up, and then you never know you have it. You just think, well, this is the way I breathe. Well, no, that's not the way you're supposed to breathe. Best example is, go in the shower, have a steam shower, blow your nose, try to clean out your nose, then step out of the shower, take a deep breath through your nose, and you go, oh, is that the way I'm supposed to breathe? Yes, that's the answer. We gave people saline rinses. They'd come back 2 weeks later. They weren't even using nasal strips, just saline rinses. 2 weeks later, they go, I'm sleeping better. The doctor, does this mean I have a sleep breathing disorder? I said, well, It could mean that, but it also means you have a nasal breathing problem that has to be corrected. And if you do that, you're going to see improvement. So think about how easy that would be to promote and advertise and say, that's all you need to do. In fact, in the book, we have whole sections on this early conservative treatment steps because you can get so much improvement with so little effort in the startup. And that then gets the person interested and motivated, saying, well, if I got all this benefit from this little bit of treatment, I wonder how much more benefit I could get, from a more sophisticated treatment.
What would be a more sophisticated treatment?
Well, the areas that people are looking at nowadays are the PAP machines,
Hmm.
dental devices that hold the jaw thrusted forward. There's other innovations that keep coming to market. Some of them are worthwhile. Some of them are more gimmicky. Um, PAP therapy is still the biggest one. The pharmaceutical industry is finally getting involved because they realize this is $1 trillion market, and they're trying to develop drugs that will improve the strength of the airway dilator muscles, including the base of the tongue. So we'll probably have some drug solutions in a decade that are maybe pretty good. They have some now that are not very good, but they do something. And that's why they're going to market already with some of this stuff. Why are they going to market? Because everybody hates CPAP. And
Mhm.
that's a whole other discussion, which is that we stopped prescribing CPAP 20 years ago. We think it's not a good version of PAP therapy. And I describe again in the book the fact that bilevel is a very different kind of PAP. And we don't think people who struggle with PAP should have to struggle more than 30 minutes. Instead, and what happens in sleep centers all over the world, people say, oh, just try harder. Just try hard. I'm quoting you verbatim what patients are telling me. They're because I have a sleep coaching service at my website, and they come to me because they've gone to all these sleep centers and nobody will give them the truth about why CPAP doesn't work. And CPAP doesn't work because it's one pressure all night long. And people don't like that. It's too difficult to adjust to. So we switched to bilevel devices in 2005, and we can get, as one example, we published a paper showing that 90% of PTSD patients, who of course would have a very difficult time using a PAP machine, by putting them on various bilevel types of devices, we got 90% of the PTSD patients to be at least using it somewhat regularly. 60% of them were using it very regularly, and another 30% were using it, partially and gaining, some benefits. That's a very big deal. And you would think, why wouldn't that information be out there? Instead, most PTSD patients are told they must start with CPAP. Well, here's the problem. You start with a device that causes you panic attacks, claustrophobia, feels traumatizing. You rip it off in the middle of the night. How likely are you going to go back to that doctor and say, you know what, that didn't work. Can you give me something else? No, that patient's going to be pissed off and angry that they were put through this nonsense, this torture, because they didn't have to. If somebody would have just said, well, let's talk about the concept of PAP adaptation and desensitization. How can we help you get on this and use it regularly? And there's a whole system involved, and it usually leads to getting them off of CPAP very quickly and onto bilevel very quickly. And we found the insurance companies were very receptive to this. Why? Because they knew it was good for their patients. Yes, it's a little bit more costly, but they understood that we explained the patient is failing CPAP. They're not going to be able to use it. Can't we get them on something? And they said, sure, let's go down that pathway. So I marvel at these sleep doctors all over the world that say, well, insurance won't cover it or insurance rejects it. I have no idea what they're talking about. We talked to all of the medical directors of the insurance companies, even Medicare. We explained what we were doing. We said, these people are not getting a good response to CPAP. We want to put them on bilevel. They said, go for it. Absolutely, go for it.
What is the breakthrough nightmare treatment that you discovered?
Well, it's actually twofold. Number one, research now has 9 different studies published. They're not the best studies, but they're, you know, good studies with by now several hundred people have been examined where their nightmares decreased when their sleep apnea was treated. So that itself is going to become a treatment for nightmares. What we developed back in the 1980s and 90s is much simpler. It's a psychological technique. It's called imagery rehearsal therapy. And what it means is that the human mind has nightmares, obviously, because the person has had something prior to trigger the nightmare, whether it's trauma, whether it's stress, whether it's a divorce, whether it's a conflict, whatever mental psychological struggle, nobody would be surprised that you develop bad dreams about such experiences. Some people have a propensity for this to become chronic. And in PTSD patients, it becomes very chronic, especially if you have what's called interpersonal trauma. For example, sexual assault or combat. Those kinds of traumatic experiences lead to PTSD with nightmares in 80 to 90% of the cases. Interesting, fact, PTSD from a car accident, for whatever reasons, the number with nightmares may be far less. And I don't think anybody knows the reason for that. That's just data that was published. Anyway, what we learned is that nightmares over time function like a learned behavior. They function like their own independent learned sleep disorder or learned mental disorder, where the brain has just picked up this habit, which sounds really strange because we're not trying to dismiss the trauma, we're not trying to dismiss the nightmares, but the brain works this way. So if you take your bad dreams and you rescript them and you say, well, I want to dream something different. That was my nightmare. I'm going to turn it into something different. Now I'm going to practice that during the daytime. That actually decreases nightmares at night. And it decreases it big time. And it's so big that it actually decreases PTSD severity. And by the way, what we're doing, even though we call it IRT, imagery rehearsal therapy, it's not new. There was a guy who published this in a psychiatric journal in the 1930s, describing how he took a group of very young children suffering from chronic bad dreams. I believe many of them probably at the time would have been diagnosed with PTSD. And he said to them, what do you want to dream about tonight? So the technique then was called auto-suggested dreaming. And he published this paper in the 1930s showing, his name was Dr. Weil, W-I-L-E. I think it might have been Ira Weil, I'm not sure. Anyway, Journal of Orthopsychiatry or American Orthopsychiatry. And the children got better. So it just sits there in the scientific literature for 50 years. And then we come along and Dr. Robert Kellner and Dr. Joseph Neidhart learned about all this stuff from a couple of other case reports published in Britain in the 1960s and 1970s. And there in the 1980s, they developed this program. It gets published in the American Journal of Psychiatry in 1992, and then more publications throughout the 1990s. And then finally, in 2001, we did this major study on rape survivors, women who had all been sexually assaulted, all who had PTSD, all had chronic nightmares. They had moderate to severe PTSD, some very severe PTSD. And their nightmares got better with this simple technique. And they learned IRT, their nightmares got better, their sleep got better, their PTSD got better. That got published in JAMA, because Journal of American Medical Association, because they go, well, we have a special weekly journal in the month of August that's all about trauma. So they picked it up immediately. It was the lead article, and it's been out there ever since. It's the most widely published, cited article regarding nightmare treatment in PTSD patients, because it works and it actually decreases PTSD severity. Now, just as a footnote, these were the same women, it was close to 200 women that who would come to us for help. Not all of them were in that study, but they entered into that protocol. We tested many of them and they had sleep apnea. And we never knew that till years after this initial study testing them for IRT. And that's why I say this complexity was first we did IRT for their nightmares, then we did a technique called cognitive behavioral therapy or CBTI for their insomnia. And then down the road, we learned about sleep apnea and we started treating them with PAP therapy. And so that's why I say it's a multi-pronged, multidisciplinary treatment for PTSD patients that has so much potential to help them.
Yeah, so if they were having nightmares, they would be more likely to wake up with the breathing problems during the nightmare, right?
Right. Not only that, but there's been a theory for a long time that breathing, dreams about breathing or having difficulty breathing is actually the cause of the nightmare. And so, of course, you have a breathing event. You feel like you're under attack. You feel like you're suffocating. So why wouldn't you wake up?
Yeah. What is the breakthrough insomnia treatment that you developed?
That's all about the fact that you can use PAP therapy. But there's one particular component of this that's the true breakthrough regarding PAP. And that is we published a paper in the premier journal Lancet. They have an online journal called eClinical Medicine. And this was published 5 years ago, 2019. And we published a study based on a grant we received from a major sleep vendor called ResMed. Most people know that name because that's the most common PAP machine device on the market today, especially because the other company, Respironics, basically went out of business because of a scandal involving carcinogenic material inside their PAP device. So most people know of ResMed, and we talked to ResMed for years about this idea that chronic insomnia, because of its breathing component, needs a PAP machine, but you're never going to get a great response to CPAP because CPAP, with its one
You're
pressure,
you're breaking up now. We've got a great editor, so I'm going to go back and
makes
the
it
last thing that
so
came.
difficult to breathe out again. And we said, you have a device called ASV. Sure. I just saw something about an unstable internet because I can't hear you now. Are you talking?
Can you hear me now?
Yes.
Okay. Yeah, you had about a period of maybe 30 seconds when you were breaking up really bad.
Do you
So,
remember where we left off, where that started? I mean,
you were talking about the equipment and I would just go back to
yeah,
the
I've got
um
it. I know where
okay.
to go. I know where
All
to go.
right.
And just
Great.
tell me if this sounds good. So what we learned was that you can't use CPAP. You really need a different device, but the way science and research works, you have to prove it. And so ResMed was very generous and gave us a grant to study CPAP, the standard treatment, versus ASV, adaptive servoventilation, which is just a very, very fancy form of bilevel. And bilevel simply means that you get a higher pressure when you breathe in and a lower pressure when you breathe out, which is so much more comfortable and so much more easy to adapt to. So we did this study. It was a very intriguing study because we specifically wanted to demonstrate not just that this device is better, but we wanted to show the world how insomniacs actually understand or don't understand their process. So what do I mean by that? The people who are in this study, there's only about 40 people, they had to meet a very specific criteria. They had to have a sleep breathing disorder, but they didn't know it. In other words, when they walked in the door, they said, I have chronic insomnia. I don't have any breathing problems. I'm not sleepy during the day. I'm not overweight. I'm not here for some sleep apnea evaluation. We said, okay, that's fine. By the way, we have a research protocol for you to actually treat your insomnia. Would you like to know about it? And they go, sure, sure. Tell me about it. So we do this interview with them and so forth. And we say, so, you know, um, I understand that you have this belief that your chronic insomnia is all psychological, right? I mean, you've been to doctors, therapists, you've gotten pills, you've had psychotherapies. I mean, on and on and on. And they go, yeah, that's what I believe. Say, okay, well, guess what? You are now eligible to go into this study. And they go, well, what's the study about? The study is about the possibility that you actually do have a sleep breathing problem. And what we do is we'll go and test you. And if you do have a sleep breathing problem, then you're now enrolled in the study if you want to go forward. And then we will randomly assign you to CPAP or ASV. And because these people know very little about any of this, they're not going to know the difference between CPAP and ASV. They're just going to say, well, they gave me this machine and they gave me this machine. They look the same. To them, they wouldn't know necessarily to say, oh, that feels this way or that, that kind of thing.
Mhm.
So what happened was these people, to get these 40 people, can you guess how many chronic insomniacs we had to interview through our what's called our intake system? How many do you think we had to interview before we got the 40 people? And how long do you think it took to get the 40 people? I'm just not trying to put you on the spot. I want to know if you have a guess.
40 people.
How
What
long, how
did,
long, how long did it
oh,
take to find the 40?
how
In other
long
words,
did,
there were some people who weren't eligible. They were
oh,
overweight, or they
okay.
were had snoring, or they were sleepy, but they came in saying, I have insomnia. They said, I have insomnia. I want treatment for my insomnia. That was the first category.
And they couldn't be overweight,
Couldn't
right?
be overweight, couldn't be sleepy, and couldn't have breathing symptoms like snoring.
Did
So
it
how
take,
many people did we have to evaluate to get to our 40?
I
Just a
don't know how
guess.
many people. Did it take you 6 months?
It took more than 2 years,
2 years?
and there was more than 1,000 people.
Wow.
So think about that.
A lot more
That
than my
means
40. Your
right,
overweight got me because I'm thinking a lot of them were overweight.
right, right. So think of what this means. This means out in the real world, people who are walking in the door to get insomnia treatment anywhere, primary care doctor, psychiatry office, their therapist, wherever, many of them do snore. Many of them are sleepy during the day. Many of them are overweight. And so that means any of these healthcare professionals, when they hear the word insomnia, they go, okay, I know you have insomnia, but guess what? You also have some breathing symptoms. You're also sleepy during the day, or you're overweight. You may have something else going on here.
Mm-hmm.
So it took us 1,000+ patients to get to the 40 who had none of that, because those are the people that nobody would suspect has the condition. We divided them up into the two groups, CPAP and ASV, and it was just total difference. We evaluated them every 2 weeks. At the end of 14 weeks, nearly 70% of the people on ASV were technically cured of insomnia. These are people who
Wow.
had all kinds of other treatments in the past,
Mm-hmm.
drugs, therapies, and so forth. Nearly 70% cured. And what do I mean by cured? I mean on a major validated insomnia severity scale that everybody in the field knows about and uses. We got scores lower than people get when they get psychological treatment for insomnia or pill treatment for insomnia.
Mm-hmm.
The CPAP group could only do that in about 25%. So one group was 70, that's ASV. The CPAP group, bless its heart, CPAP got 25%. And so you're talking about breathing and improving breathing can have a dramatic impact on insomnia. And that was published in 2019. And people now are beginning to see that paper. It is obviously why I wrote this book afterwards,
Mhm.
because I wanted people to know how important it was to look at sleep breathing and look at this advanced PAP machine for the treatment of insomnia.
Now, we have run out of time, but I want to talk about one more thing, and that's people who have trouble falling asleep.
Great. So the trouble falling asleep issue is clearly something that looks more psychological. And in many cases, especially in younger people, it is more psychological. And that requires special kinds of treatments that are called CBTI, cognitive behavioral therapy for insomnia, but also the IRT treatment I described to you, that can work for them. There's also something called sleep related emotion focused therapy. Again, I've written about it in the book. It's needed for some very difficult, complex patients with difficulty falling asleep. However, won't surprise you for me to tell you, many people, we actually published a paper on this, where we took out people who said, I have a problem falling asleep at bedtime. And we looked at their data and published a paper showing that just by putting them on a PAP machine, many, not all, but many of those patients had statistically significant, meaningful changes in the time it took to fall asleep. Why? Because they actually were having breathing problems as they went to sleep and didn't realize it. And it was waking them up. And that is not uncommon for somebody's breathing to actually sort of taper off, become shallow, and then it wakes you up as you're trying to fall asleep. And you don't know it. You just think, oh, well, I'm still awake. I'm still awake. You didn't know you went through that cycle. So both the psychological and the physiological, again, are essential for people with the what we call sleep onset insomnia.
Okay. And one more question for the coaches out there who want to help. They're not really, it's not really within their scope of practice to work with them on a lot of the things that you've talked about, but some of the things maybe that they could work on is maybe weight loss and breathing exercises and uh, food and things like that, right?
Right.
What would
Well,
you
that's
recommend?
that's always an approach, but I would actually what's the word, upgrade, upteach. There's that phrase that no, these individuals can read this book and learn so much they can apply many of the educational components of what we've talked about. And so on my website, barrycrakowmd.com, I do sleep coaching for individuals. But the way this is growing, I'm probably going to be doing seminars, training coaches of all types,
Mhm.
giving them a program to say, here's how you can actually introduce your own sleep coaching, because this sleep thing is so big. You can't just rely on the sleep centers, the sleep doctors. There's a component called behavioral sleep medicine. It has its own specialists. They're very good, they're very competent, but they could never manage the whole populace that's suffering from this
Right.
problem. Health coaches of any type can learn stuff from my book and from the seminars I'm probably going to be having to give. And once they learn this, they're going to recognize there is so much more they can apply to their clients without having them to go, just like that to the sleep center. They're going to
Mhm.
need sleep testing and all that at some point. But no, your health coaching audience, they can learn so much that they could do and actually make their patients feel and sleep better long before they even get to a sleep center.
Okay. Thank you so much for being here today. We're going to have all the information on how to reach you underneath the podcast on our website. So we'll have your www.lifesavingsleep.com there.
Great. And then my website for this coaching and other videos. By the way, there's a free video on nasal hygiene on my website, www.barrycrakowmd.com. And I also have a free Substack newsletter at fastasleep.substack.com. And I have another book coming out later this year called Fast Asleep.
Great. Great. Well, thank you very much.
Well,
I've
thank you very
enjoyed our
much.
conversation. It's been very helpful for a lot of people, I'm sure.
Thank you very much for your time. It was a very good conversation.
You're welcome. Bye-bye. Have a great week.
Bye-bye.